All right, now we are going to move on to our next segment, Everyday Living Tips with ALS. So I think this is going to be a really pertinent session for all of you that are listening with us today. And I want to go ahead and introduce to you our three panelists who are going to be speaking. First, we will start with Ginna Gonzalez. She went to college at University in Javeriana in Bogota, Colombia. She received her master's degree as a nurse practitioner at the University of Miami and did her training in primary care. She received a doctorate in nursing practice at the University of Miami in 2009, and she began working at the neurology department at the University of Miami Miller School of Medicine in 1997. She's implemented and developed the ALS Multidisciplinary Clinic in the same department. She is currently Director of Practice at the Alexion Family MDA ALS Center and dedicated to see patients with neuromuscular diseases. She has cared for patients with ALS and participates in different research studies to find the cause and cure of the condition for more than 20 years. Then we will hear from Adriana Lopez, who is our occupational therapist, and she's been doing that for 34 years. She earned her degree at the La Universidad Central de Venezuela. She has experience in pediatric and adults home health services in the Houston and Miami area and an acute setting at Mercy Hospital in Miami. She's been working at the University of Miami since 2015 and is part of the neurology neuromuscular department as OT for the ALS clinic and also for the MDA clinic and wheelchair clinic. And then finally, we will hear from Matt Caraher. He is a doctor of physical therapy and a board certified neurologic physical therapist with the University of Miami Health System. He has been with the organization for the past 6 years as a senior therapist. He provides rehabilitative care for patients with a variety of neurological conditions and is specialized in the needs for individuals with neuromuscular conditions such as ALS. In addition to patient care, Matthew also serves as a physical therapist for the University of Miami ALS Multidisciplinary Clinic and an adjunct professor in the University of Miami DPT program, as well as a program director for the University of Miami's PT Neurologic Residency Program. So that will assist new graduate physical therapists in specialization with the realm of neurologic rehabilitation. So thank you all for being with me today. You guys are all very busy, so I appreciate your time. Ginna, I will have you begin, and then we'll hear from Adriana, and then we'll follow up with Matt. So you can go ahead.
Let me start with everyday living tips with ALS. I imagine the majority of the people right now, they were diagnosed with ALS. And as you know, primary diagnosis is based on the detailed history of symptoms and signs that is observed by the physician when they go to see for either the primary diagnosis or second opinion. When you leave the neurologist's office, you don't understand what happened. You don't know, you don't believe, you don't understand anything. And at the University of Miami, for that reason, we create a unique program that is called Second ALS Clinic. 2 weeks after you receive the diagnosis, the patient come back to see me along with the psychologist, social worker, and the research coordinator. I explain the patient about the disease process, possible treatments. The social worker will talk to them about disability, the help at home, and how to register with different associations like MDA, ALS associations to try to get more help. The psychologist is also talking to the patient and the caregiver how to cope with the disease and with the new diagnosis they just received. The hope is coming from the research coordinator because they are going to explain about research opportunities and clinical trials available for them. I have Mr. Hoffman that he said nobody has an idea what is to live with ALS. He also said most people don't have the capacity to navigate all this. I never met anyone who could do it alone. And I will ask, who's affected by ALS? Some of the patients said, I'm affected. But in reality, we have the family affected by ALS, children, husband, wife, and friends are affected. You are not alone. You have the family, you have your friends, you have what we call the circle of trust. Positive attitude is important. Every time they see me at the office in the Second ALS Clinic, I say, this is the medication that exists, approved by FDA, this one, But the most important is the positive attitude that you can get with this disease. When you have a positive attitude, have a higher perceived quality of life. Also improve coping, even in terminal patients with physical limitations. Everybody remembers Stephen Hawking, and everybody is doing analysis, research, why this person lived more than 50 years with ALS. Well, they're finding out that the patient has a really positive outlook on life. Positive psychology, the science of happiness, of essential part of everybody's well-being. Well-being depends on finding the balance between feeling happy and having a rational understanding of the future. Learn all you can about your illness. Knowledge helps eliminate irrational fears about the future. Practice mindfulness and gratitude. Learning to be mindful helps keep your thoughts in the now. Why are you thinking in the future? We never know what is going to happen in the future. I don't know what is going to happen in the future. Some people think, oh, because I'm going to die. I had a lot of patients that unfortunately the caregiver died first. It means don't think about the future, always think about the now. Surround yourself with optimistic people. Caregivers, family, and friends all have the influence in your mood. Spend time with people that radiate positive energy. This is what you need, people positive around you. Check in yourself. Establish the habit of asking yourself these three questions. How do I feel? What do I need? And who can help me? For example, I feel thirsty. I need a drink. I will let my caregiver go. What about if you feel lonely? I need a conversation. I will call my friend. That will be a good way to do it. This disease may cause a lot of stress, and unfortunately, stress is affecting psychological and physical. It will bring a lot of problems. People feel depressed, they feel anxious. Physical problems is coming from heart conditions, eating problems, muscular pain, memory and concentration problems. That's a lot of problems that stress brings to you. They have some relaxation techniques, abdominal breathing, visualization, meditation, guiding imagery. And if, for example, you want a tropical setting, you can imagine the warm breeze in your skin, the bright blue of the water. Close your eyes and feel that. The sound of the waves, the smell of the flowers, and actually you can feel the taste of the coconut. That's what some of the psychologists use with the patients to try to distract the patient from the stress. Take care of yourself. There are many activities that you can do to take care of yourself. Bubble bath, massage, go with your friends, get a drink, go and have dinner. Just go and do some exercises, share responsibilities. That will be very important for you. What is more important is ask for help. That's why you need to surround around people that can help you, your friends, your family. Combined strategies work better than trying to do only one thing. For example, you can see the psychologist, but you can do exercises, you can practice medication, or just simply make a decision to phone a friend and chat about the problems that you have. How to cope with the disease. Discuss feelings, okay? This is one of the, I would say, major problems that we have with couples. They don't communicate, okay? Sometimes the patients, they don't want to worry the loved one and tell that they feel depressed, that they feel sick, that they feel down. And at the same time, that happens with the caregiver. They don't want to talk to the patient and worry the patient more that they feel depressed. We are seeing a lot of divorces in couples, and it's because of lack of communication. Talk to the other person, communicate your feelings. It's very important. Let those who love you know how much you appreciate their help. And look at that, I highlighted. I think this is one of the most important things to do. The American Academy of Neurology developed practice parameters to assist clinicians in providing high-quality assessment and treatments that is consistent with the scientific evidence. Right now, everything that you do is scientific evidence. They need to have studies done in order for you to practice that. For example, they do a study that the patients that they walk 10 miles, they survive longer than the patients that they walk only 2 miles. The recommendation of the clinician is to try to tell the patients, okay, you need to start walking 10 miles because the studies are showing that the patients live longer. Unfortunately, bulbar symptoms are the more critical with ALS. If you have weakness in your legs, if you have weakness in your arms, yeah, nobody wants that, but you can live longer. Bulbar symptoms is more critical. Swallowing problems may cause weight loss or sometimes aspiration pneumonia. We have some strategies: nutritional and caloric management, monitor your body weight and BMI is important, and optimize the timing of the gastrostomy tube. The studies are showing that low BMI is associated with rapid progression of the ALS and shorter survival. There are muscle atrophy due to neurogenic causes, is when the motor neurons are affected and they have degeneration, or because it's a nutritional muscle atrophy. You don't have adequate caloric intake. That's the two differences. And I know that the speech pathologist talked to you a few minutes ago, but I would tell that it's some major issues that may impact the quality of life of the patients: coughing and choking, weight loss, aspiration, and more. What will be the management tips for that? Get a consultation with the dietist or with the speech pathologist. Compensatory strategies for consistency changes, monitor food intake to keep your weight stable, monitor the weight weekly to catch weight loss early. Stop those diets. For example, a friend is telling you, or Dr. Google is telling you, that if you remove the gluten from your diet, or the fat from your diet, or the carbs from your diet, you're going to live longer. And you start doing that, removing all this type of diets, and the patients start losing weight and the disease progresses faster. When you notice that you start losing weight, try some supplements. They are very high in calories, like Boost or Ensure. And the last resource will be the feeding tube. A lot of people will be scared of the feeding tube, and I have to tell you that I used to work in an endoscopy center. This is a very simple procedure. After I talked to the patients and they are so scared to receive the feeding tube, they said, Ginna, thank you for that recommendation. My quality of life improved a lot after I had the procedure done. This is under local anesthesia, mild sedation. The insurance will cover the supplements, and it's 100% nutrition. When are you going to decide that you want the feeding tube? First of all, when you have swallowing difficulties, when you start noticing that you're losing weight, and something important is when your vital capacity falls to 50%. Some of the patients, they don't have any swallowing difficulty, they feel stable, but the breathing is affected. At that moment, we have to think about feeding tube, because at this moment with 50, it's a very simple procedure. When the vital capacity is lower than 50%, it's very complicated to do the procedure in an endoscopy suite, and we need to think about different alternatives. There are studies done in 2018, and there were more than 1,000 patients. It was a meta-analysis study, and they determined that the patients with feeding tube improved quality of life and increased 20-month survival rate. I will tell you that the patients using feeding tubes and non-invasive ventilatory supports, they have better survivors than when they are taking medications approved by FDA. And this is in the studies done in the past. Tip for swallowing: the speech pathologist talked to you about that, but it's important to change the consistency of the diet. moisturize the food with sauce or gravy, and take sips of liquids when you're eating solids to prevent that it's going to be stuck in your throat. This is another major concern for the patient, salivation and drooling. The majority of the time is caused because you have a lot of weakness in the muscle helping you to swallow, okay? We never realized that we produce so much saliva, from 4 to 6 cups of saliva. I didn't know that we have so much saliva. And unfortunately, some of the patients, they feel like they're embarrassed to go to have dinner with their friends, to go to restaurants, and they are isolated. There are medications that we can use to control the saliva, like anticholinergic medications like glycopyrrolate, and they have the liquid form that is glucosa. Unfortunately, some of these medications, they may cause constipation. That's why we need to make sure that we can adjust the medication. Other medication is a scopolamine patch. We're using sublingual atropine that is helping, not as better as the glycopyrrolate, but is helping a little bit. The myoblock is the type of Botox that we use to inject two of the salivary glands. Unfortunately, this is a temporary effect. Like every 3 months, the patient needs to be injected. But it's working. It helps the patient to control the saliva. The other option is radiation of the salivary glands. They also, again, radiate only 2 glands of the 4, but this is permanent. If they feel that it's too dried, it's nothing we can do unless we can start putting medications to moisturize a little bit the mouth. There are non-pharmacological strategies like using a suction machine, good oral care. It is important that you talk to the occupational therapist about head posture, body posture. Sometimes by gravity, the patient is drooling a lot, and it will help with the right posture. The toothpick, I hope a lot of people, they hear about that. It's a toothbrush that is connected to the suction machine, and it will help the patients to prevent risk of aspiration pneumonia when they have a lot of saliva. When you're brushing your teeth, that you create a lot of saliva, water, it will prevent aspiration pneumonia. Constipation is another major problem, and external causes like low fiber, caffeine abuse, medications for pains, they can cause a lot of constipation, like lack of movement, lack of fluid intakes. Those will be the multifactorial cases. In most people with colonic motility occurs when they're taking laxative for many, many years, is laxative abuse. Coughing, choking episodes. When they have those cases, patients prevent or avoid drinking water, and for that reason, sometimes they are dehydrated. We need to drink water. We need to use the thickener to avoid the thin liquids to go to the lungs. I mentioned a few minutes ago about the non-invasive ventilatory support. A lot of people hear this, they're very scared. It's very similar to the machines when you have the sleep apnea, you sleep with a CPAP machine. It's more or less similar to that, but they did studies also long time ago, like 20, 25 years ago. They did a retrospective study of more than 200 people, and they noticed that the patients that were using the BiPAP, the survival was 14 months more than the patients that they were not using the BiPAP machine. It means it will improve quality of life, symptoms of hypoventilation, and increase the survival for many months. How do you know if I have a hypoventilation? We can recommend to do the overnight pulse oximetry, and they check the amount of oxygen that you will have in your blood. The same thing, the amount of carbon dioxide that you have. When you have high amount of carbon dioxide, you feel sick, you feel tired, you don't want to do anything, you don't have energy, and in the mornings you have morning headaches. It means that it's a very simple procedure just to capture that your oxygenation is not doing well. The other thing is the spirometry, either slow vital capacity or forced vital capacity. In our clinic, we use the slow vital capacity. It's easier for the patients, especially when they have bulbar ALS, and it's measuring how much air you inhale and exhale. Okay. When those tests they get to 50% is when we recommend the breathing machine. I'm going to talk about the upper and lower extremities. We have Dr. Matt Caraher and Adriana Lopez talking about that, but I want to emphasize about aches and pains. The management of that, sometimes patients, they are complaining of a lot of muscle pains, and it's sometimes the lack of movement. Stretching and massage is important. Physical therapy, medications for spasticity, anti-inflammatory medications, and please do not take narcotics. Sometimes the patient feels like I have pain, I need to take Tylenol number 3 or codeine to avoid those pains. And what is happening is giving you more constipation, addiction, it's covering the pain, but it's not resolving. ALS symptoms affect every patient differently. Treatment requires several different types of healthcare providers with diverse and specialized skills and knowledge. Instead of the patient start going to different offices to try to get the input from the specialist, we are providing like what we call one-stop shopping in the university. And you can see in 3.5 hours all the specialists. The studies are showing that patients with ALS who receive their care at a multidisciplinary clinic had a better prognosis than patients attending a general neurology clinic. The clinic was developed to maximize patients' independence, to help with the quality of life, and for the patient to continue in the community. It was found in the studies that the patients participating in ALS clinics, they live 7.5 months longer than the patients that they go to the regular neurology clinic. And you can see here, in the middle is the patients surrounded about different specialists they are giving direct care of the patient, or in blue, the people that is by referrals providing services to the patients. Not only the nutritional, they can check for weight loss, the feeding tube, the psychology, depression, cerebral affect, the social workers working with equipment, help at home, hospice services, palliative care, respiratory therapists who work with non-invasive ventilatory support, the cough assist when the patient has difficulty removing all the secretions from the lungs, the physical therapists and occupational therapists, they treat the cramps, spasticity, exercises, teach the family how to continue maintaining good range of motion and prevent falls. The speech pathologist will talk to the patient about different communication devices. And something that is very important is to do the voice banking. And I hope somebody talked to you about voice banking early in the disease, because you can save your voice if you need it for the future. At the University of Miami, we have the multidisciplinary clinic. As I mentioned, it's 3.5 hours, either in the morning or in the afternoon. And you don't need to go to different offices to get the information from the specialist. The patients discuss all the concerns about the disease. They bring all the symptoms that they have to receive the information from the specialist. And at the end of the session, the patient leaves with a lot of educational material, prescriptions, assisting devices that we need to order. At the end of the clinic, we have a meeting with all the specialists, and we generate a treatment plan. We send the treatment plan copy to the PCP and the referring physician. And the reason of that is because we need all of us, we need to be on the same page. If you call the primary care doctor with any problem, they can read that we are recommending this medication or this equipment for you for whatever problem you have, but they need to be on the same page. The team's focus is to implement a plan of treatment towards a common goal, improving the patient's quality of life. This is the multidisciplinary clinic that we have in the University of Miami, and we do some referrals. We don't have the pulmonologist, the gastroenterologist, but we refer the patients to those specialties if it's needed. And I'm going to mention about palliative care. My experience with palliative care is very positive. They can do a close supervision of the patients, and also they have an interdisciplinary team to help the patients and families. The main goal for them is also improve quality of life, to help with physical and psychological and spiritual. They do supportive care, pain and symptoms management. They have the interdisciplinary focus, resources, and they can help with the transition to hospice care. Sometimes patients, they feel afraid to hear palliative care hospice, and the way we do it is hospice and palliative care, they provide care to you instead of putting connected with death. We don't do it that way. I think it's more services that they can provide that you can maintain the quality of your life. And I'm going to show you, this is our team. Here we have research and clinical. Thank you very much. I think we're going to have some questions later on.
So my name is Adriana Lopez. I'm the occupational therapist in the ALS clinic at the University of Miami. Okay, as part of my role as the occupational therapist in the clinic is to evaluate the current status and function of the patient. I try to complete to find out how they are performing the activities of daily living, like eating, grooming, toilet, taking a shower. I also look at the muscle tone, how's the muscle strength, how's the range of motion in the arms, is you have any pain, if you have any limitation. Also, we kind of like try to assess what we call the instrumental activities of daily living. There are more like cooking, laundry, going to the grocery store, things like that. And based on this assessment, we do our recommendations. Of course, these are short sessions, so we try to get as much as possible. And based on this assessment, we can recommend even an exercise program or just little strategies to help perform these activities of daily living a little bit easier. Or if we need to, we can make a referral for outpatient or home health therapy. Exercising is super important. Ginna was mentioning, and I know Matt is going to cover a little bit of that, but there is evidence and show that moderate intensity exercise can be very beneficial to improve and maintain your quality of life, can maintain the muscle strength, the flexibility of your joints. A good exercise routine, some people say like, oh, but my arms are too weak, or my wrist cannot move, but like you can still continue doing these exercises and they will maintain the strength of the unaffected muscles, and then will prevent or slow down future limitations of the affected muscles. These are some of the limitations we find in some of our ALS patients. Frozen shoulder is basically when the soft tissue in the shoulder becomes like stiff and immobile, and they have like a scar tissue that start getting very hard, so you have difficulty moving your shoulder in the proper range. This is going to make difficulty. It's going to make difficult to dress, to perform hygiene. Wrist drop is when the muscles that extend your wrist are weaker, so your wrists tend to like drop down. And finger contractures is kind of the same of the frozen shoulder. You have these scar tissues and the fingers tend to crawl in, and eventually if like you don't do a good prevention, it can make like really hard for you to straighten your fingers. I like to again emphasize is like most of these limitations can be prevented or really slowed down with a good exercise program. Sometimes we also order some orthotics, like for example, like a wrist support, just to maintain the wrist in good alignment. And then you can use your fingers a little bit better and easy to do your activities, or like a resting hand splint that, as the name say, is for resting time when you are sleeping or just like sitting down watching a movie. That's gonna keep your wrists and your fingers in a functional position, and it's gonna provide a prolonged stretching of the fingers, and like that you can prevent some of the finger contractures. Oh, hold on. Okay, here are some of the tools that I like to recommend for the patients to be able to do exercises on their own at home. The first one is a restorator. You just put it on top of a table and exercise your upper body and your arms. There is a little knob that you can change the resistance. The next one is a pulley that you can hang over the door. And when one arm comes down, the other one goes up. And like that, you can perform a self-stretching of the shoulder joint. There is just a bar that you can grab with both hands, and you can do bilateral exercises with both arms. As the ALS progresses, the activities of daily living can become very difficult to perform. There is a lot of assistant devices available that will help you do these activities a little bit easier, and it will maintain your independence as much as possible, as long as possible. And this now technology is amazing. They have these other devices that can be voice activated, that is very accessible to everybody, including Alexa or Siri. You can just tell Alexa, turn the light on, or turn the TV on and change the channel. There are a lot of that type of activity, assistant devices, but they are like smaller things that can help make your daily routine easily. Sometimes I hear from our patients that say like, oh, but that would be giving in. I'm gonna do it by myself as much as possible. That doesn't really mean giving in. My best example is that we use all of these devices and like in our daily routine forever. Like if we think about the kitchen, we have the electrical food processor, we have the dishwasher. It doesn't mean that without those, we cannot wash the dishes or cut our own vegetables. It just means that it's gonna make our life a lot easier. These are some of the assistant devices. These are very, very tiny examples. There is really, really a lot of information about this. The first one is like a tubing that you can buy in different length and in different like thickness, and you can put over like anything like utensils, razor, the toothbrush. You can make it longer if you have difficulty bringing your arm up, or you can just make it thicker if you have difficulty holding it, and with your fine muscles of the hand. They are utensils. They can be bendable. They have like a different arrangement. The next one is a, I don't have my mouse. This one is what we call a universal cuff, that you just put it around your wrist, and there is like a little pocket where you introduce the utensils, and then you don't have to hold the utensil down. An adjustable table, like if you have weakness in your shoulders, and instead of having to bring your head down in order to be able to eat, you just place the items in a higher level. A plate guard if you have weakness on one hand, so you don't drop the food on the table, and long straw. These are like for grooming, ideas for grooming. They are lawn combs and brushes. If you have weakness in the elbow again, if you have hard time like holding the hair dryer for a long time, they are holders for the hair dryer. Again, you have the foam tubing, you have nail clippers that you can just press down instead of having to hold it with the small muscles of the hand. For dressing, we have button hooks, if you can use just one hand, long shoehorns, long sponges like reachers, if you have to like reach for something higher, or for something that dropped to the floor. Shoelaces that are elastic so you don't have to tie them down. For toileting, we have bidet attachments. There are the urinals. They can be for women or for men. They are the razor for the seat. If you have difficulty going from seat to stand, the bedpan, or a toilet aid just to wrap the toilet papers you have a hard time reaching. For bathing, I think that one of the main things would be like safety. So grab bars are always a good idea in the shower. Long sponges, not only for the back, but for the foot. Transfer bench, if you have a bathtub and you have difficulty going in and out of the bathtub. Handheld showers. The instrumental activities of daily living are cleaning, like cleaning, cooking. We look at assistant devices that can help you with that too. My main suggestion is for everybody to be proactive, act instead of react. Anticipate what can happen and try to obtain the information from all of your specialists. You have the MDA Association, you have the ALS Association, you have all of us here for you guys. So always let us know if you have any limitation, if you have any pain, any concern. We'll help you out and try to anticipate before it becomes like harder. So thank you.
Good evening, everyone. My name is Matt Caraher. I am the physical therapist with the University of Miami ALS Multidisciplinary Clinic. And to kind of wrap up our session today, I'm going to be talking to you about tips and tricks to maintain an active lifestyle. One of the things we really like to impart on with all of our patients is it is still possible to have an active lifestyle. It is still possible to exercise. There are safe ways to go about it, and it will help you maintain quality of life. It will help to reduce stress. It can be a great family activity, and it's going to make you feel like you are doing something. I know that many of you out there who are experiencing this disease, or many of you family members who are experiencing loved ones going through this, you want to feel like you are actively doing something to kind of combat the process. And one of the best things you can do is, as Ginna said earlier, maintaining a positive attitude, but also keep moving to the best of your ability. So things that we should be considering before starting an exercise program is the exercise style, right? There are many different exercise styles out there on the market. There's Zumba classes, there's CrossFit, there's traditional exercise programs. There are devices that you'll see on television for exercise. We are in a kind of advertised heavy social environment, right? So what we want you to be wary of is how to exercise, the style you want to do. Does it necessarily match up with your disease process? And how can you do that style and also still be safe? And that leads us into kind of the exercise parameters. So what we'll be discussing a little bit later in the presentation is what are the parameters one should consider when we're exercising in order to make sure that we're not doing any excessive damage to our muscles and to those neuromuscular junctions, which we do have to be mindful of. You want to consider your exercise location. Are you somebody that wants to exercise at home? You don't want to be out in the environment in the gym, especially in the times we're experiencing right now. Maybe you don't want to be around crowds or don't want to necessarily be in a physical therapy gym. Maybe you want to exercise with a buddy, and that's going to kind of go into that location as well. Energy conservation is going to be a huge piece, and that's not just related to exercise. That's going to be related to everything that you do. That's going to be related to, just as Adriana was saying, bathing and getting dressed. You want to think about energy conservation when you're having big family get-togethers, energy conservation for exercise. We're going to talk about how can you conserve your energy to do the things that you want to do without completely exhausting yourself. Stretching, hands down, one of the best ways that we can work on reducing any post-exercise effects. And we'll talk about ways to do stretching safely. And finally, these other pieces that will help with symptom management. Some are going to be supplements and just over-the-counter ways to manage the way that you're feeling. Obviously today, We don't have time to go into a specific program for every single individual out there. Everybody needs an individualized process. But that being said, there are generalizations that we can make in terms of how to exercise appropriately without, again, damaging ourselves and maintaining health and safety. The first thing that you should always know, what we do know from exercise research, is it is always best to do a minimum of 3 sets up to 4 sets. If you're only doing 2 sets of an exercise, this has been shown not to really give us any benefit. And on the other side of the coin, 5 sets, 6 sets, 7 sets, you hear all this stuff about supersets. Really what the evidence is showing, and this is not just individuals with neuromuscular conditions, this is everybody. 5, 6, 7 sets plus, you're not getting any benefit. And I don't know about you, I'm pretty lazy. I want to do the bare minimum and get the maximum benefit. 3 to 4 sets is what you're looking at. When we're looking to maintain strength, it's always important that we do a minimum of 6 repetitions up to 12 repetitions. Again, anything less than that, we're not really getting a great benefit from it. So if you are unable to do 6 repetitions, that means that that exercise might be too hard and it needs to be modified. Once you're starting to hit 12 reps and up, really you've kind of maxed out. You don't necessarily need to do 20 reps. And this is within the set. So when I'm saying this is the 6 to 12 goes into that 3 to 4. So a simple example is if we're going to be doing a bicep curl, I'm doing that because it's easy for everyone to see on camera. If I'm doing a bicep curl, I would do that 6 times, take a break, do it another 6 times, take a break, do it a final 6 times. The set is one component, the reps fall within the set. Remember, if an exercise feels easy, you should always consider increasing the number of reps before adding resistance. So again, if you're starting with that 3 sets of 6 repetitions, and you're getting done with that and you're like, that really wasn't much, that wasn't hard. Maybe you want to increase that to 10 to 12 reps and see how you do with that. A lot of what you're going to hear from me, as well as many other physical and occupational therapists, is it's so important that we listen to our bodies in both directions. We need to let ourselves know this was a little easy. We can push ourselves a little bit on this. We also need to be able to say to ourselves, that was a bit too much. We need to back off. We need to be a little bit more aware of our restrictions. In general, you always want to be able to be at the upper end of the repetitions before you consider adding in resistance, okay? And again, you see in the picture I have here, I've got the exercise bands. It's the same for if you're going to add in weights. It's the same if you're on machines and you're going to add cables and things like that. You always want to make sure that you have maxed out in your repetitions prior to adding in any sort of resistance. That way you know that your body's going to be able to handle it. When you add in resistance, the process kind of starts all over again. So if you are doing 3 sets, 12 repetitions, no problem, you're going to add in maybe a 5-pound weight. Guess what? You should probably, at least for one session, drop back down to 3 sets, 6 repetitions with that 5-pound weight, just to make sure that your body reacts appropriately and there's not any sort of an adverse response. Again, when movements are difficult, don't add resistance. Get really good at doing something without resistance before adding that in. Always, always, always listen to your body. If you know that you're someone that doesn't listen well to yourself, or you don't necessarily pay attention to those signs and symptoms of fatigue, you might be someone that needs to work out with a partner, and that partner can kind of hold you accountable. Hey, I noticed your last few repetitions were really not that great of form. How about you take a break? Or how about you call it there for that exercise? Vice versa, for those of you who are going to be exercise partners, you want to make sure that you're pushing your workout partner enough to be a challenge, but not too much of a challenge. And we'll talk about how to gauge that in just a moment. One of the things I want you to consider is you can exercise anywhere. You can exercise in a pool. A pool is a fantastic place to exercise. If you're still able to walk and you want to go on a walk on the beach, again, a great place to get some exercise in. Going to be a balance component that you need to consider there, but it's absolutely an excellent form of exercise. If you're someone that's interested in the traditional gym setting, that is absolutely possible. Make sure you're wearing your mask. I know we just got some information from the CDC today about vaccinations and not having to wear masks, but let's be safe for right now until we have a little bit more information on that. If you're going to be exercising with a partner, find a creative space. Find a space that's going to be conducive to the program that you want to perform. Outdoors, for those of you located in Florida, we are entering in the summer months. It might not be the best time of year to exercise outside, but cooler months will always be on the way and cooler days will always be on the way. And that's a great time to get outside and do a little bit of exercise. If you need guidance, I will tell you firsthand, you will not find a neurologist out there who will not at least try getting you to a physical therapist. I cannot recommend enough finding your local therapist, getting an idea for what a program can be like for you, and then maintaining that relationship. It does not mean that you need to see your physical therapist twice a week, 3 times a week for the rest of your life. What that means is that you can check in with that person. Maybe it's going to be once a month. Maybe it's going to be once a week, whatever that frequency you and the therapist decide to really establish your program and then kind of be able to follow up on your own independently. Work to rest ratio and energy conservation is something that we really need to consider. This is that piece I was talking about, and how do we determine what's going to be safe from a repetition standpoint, what's going to be safe from a set standpoint, how do you maintain good form? One of the things that everyone should consider is a scale of difficulty. 0 to 10 tends to be kind of the easiest way to look at this. 0, I want you to think it's incredibly easy. It's an exercise that if you had to do it all day long, you absolutely could. 10, absolutely impossible, cannot do it. So that's kind of your 2 pillars to work between. When you are exercising, you should always be between a 4 and a 6. 3, you're being too easy on yourself. 7, you're starting to get into that range where you're being a little bit too challenging. 4 to 6 is the range you want to work in. One of the other ways to think about this, if you're exercising, you could carry on a light conversation with somebody, chat about the day, chat about the weather, but if, let's say, your favorite song was on, you would have a pretty difficult time singing along to that song. That's how you know you're in the right range. You want to be in that 4 to 6, that mid-moderate intensity that Adriana touched on earlier. Resting between your sets should always be a 1-to-1 ratio, or if that's not enough time, 1 to 2, 1 to 3, so on and so forth. But what does that mean? If your exercise takes you 30 seconds to get through your set, you should be resting for a minimum of 30 seconds before starting your second set. This is a mistake that absolutely everyone makes. My favorite thing to do at the gym is to walk around and just see people do their exercises. Then you see them sit for about a second, and next thing you know, they're back to doing that again. It's not enough time. It is especially not enough time when you have a neuromuscular condition. The reason being is that your neuromuscular junctions do not function the same as somebody who does not have a neuromuscular condition. A lot of neurotransmitters, you don't need to know the names, but things like glutamate, acetylcholine, all of these things, potassium, all of these things are building up in your neuromuscular junction. The rest period is not for you, it is for your neuromuscular junctions. It is there to allow your nerves to literally clean out those chemicals so that way they're ready to shoot another neuron response, so that way those muscles will work more effectively for you. I guarantee you, if you follow these guidelines, you are going to find that you are able to exercise more efficiently and more effectively with less problems after the fact. Very, very important. Minimum rest of 1-to-1. There is absolutely no shame in needing to rest a little bit longer. If you exercise for 30 seconds and you need to rest for 2 minutes, that's what we call a 1-to-4 ratio. Absolutely no problem with that. You will never hear anyone say you're resting way too long. That is actually good for you. Pay attention to your body. If 30 seconds later after you've exercised, you're like, I'm ready to go, I can do this. Great, go for it. If you need longer, there's absolutely no problem with that as well. When planning out your exercise routine, let's say you're going to a traditional therapy setting, after your appointment, or if it's an exercise class, after your exercise class, You should, in your schedule, build out time where you know you're just going to be able to rest, okay? And that doesn't mean, okay, I'm going to go to therapy from 9 to 10. I'll be home by 10:30. Maybe it's 11:30 with Miami traffic. But when I get home, I'm going to relax. I'm not necessarily going to need to go take a nap, although if you have to, that's understandable. But ideally, you're just going to have a little bit of downtime. Read a book, watch a television show, whatever you want to do to just kind of let your body relax. Most of your fatigue should resolve within 30 minutes. So if you leave a session from therapy, from the gym, from working out with a friend, you should be tired. That's normal. Most of that fatigue should resolve within 30 minutes. You might still be a little tired after that 30 minutes. Within 2 hours, though, of the exercise program, all of that fatigue should be resolved, should be gone. It should feel like, okay, I'm back to where I was before exercising. So here's what I want you to consider. We don't all wake up every day feeling 100%. There are absolutely days where you're going to wake up and you're going to say, you know, I only feel like I'm 50% today. Maybe you wake up and you feel like you're only at 30%. Hopefully not, but if you do, it is still okay to exercise. But 2 hours after you're completed with that exercise program, you should feel like you're back to that pre-workout percentage. So if you wake up and God forbid you're at 30%, but you say, you know what, I still want to do my exercise program, 2 hours later, you should be back to that 30%. If you are not, it is not the end of the world if that happens from time to time. That being said, if it's happening consistently, if every time you exercise, 2 hours later, you're not back to that pre-workout percentage, you could theoretically and potentially be doing harm to yourself. This is why it's so important that you listen to your bodies. So important that you consider taking that time to really relax. And then next time, if you maybe didn't feel like you hit that pre-workout percentage, maybe take it a little bit easier. Maybe cut the reps down or consider resting a little bit longer in between your sets. Things that you need to consider when you're kind of checking in with yourself during a workout and after a workout. You can have muscle fatigue, you can have respiratory or cardiovascular fatigue, and you can have mental fatigue. Those are very different things. Muscle fatigue, you might feel a little bit of burning in the muscles. You might feel a little bit of heaviness. You might feel like you're a little sluggish. Respiratory and cardiovascular fatigue, you might feel your heart racing a little bit. You might feel like you're breathing a little bit faster and a little bit more shallowly. Mental fatigue, we've all experienced this probably multiple times throughout the day, depending on what you're doing. That's just that feeling of tiredness, that feeling of I can't concentrate, that feeling of I just can't talk to you right now, that feeling of just overall fatigue. 3 very separate fatigues. You can have one, you can have them all, and they can all be related to exercise. Whichever ones you're feeling immediately post-workout, they should be resolved within 2 hours following the exercise. One thing that's going to help make sure that you're not experiencing anything crazy after your exercise, something that's going to make sure that you do not have any soreness over the next few days after your workout, something that's going to help you maintain range of motion, going to help maintain strength, is stretching. Again, this time you're seeing 3 to 4 repetitions or sets. That's because in stretching, those terms are actually interchangeable. You need to do the stretch 3 to 4 times. 3 times minimum, 4 times maximum. Again, not getting a benefit if you only do it twice, and really no extra benefit by doing it more than 4 times. For muscles that feel fairly normal, like I can straighten my elbow all the way, that's pretty normal. I would hold a stretch like this for 30 seconds. I don't need to do anything longer because it feels fairly normal. I've got the full range. For muscles that feel a little bit tighter, we actually should be holding those stretches a little bit longer. Those stretches should be around 60 seconds in length. You could do a little bit longer and a little bit less, but the recommendations and evidence just show that 60 seconds is kind of the sweet spot. Stretching should feel a little uncomfortable. I tell all of my patients, I want you to be uncomfortable with this. That doesn't mean I want it to be painful. And those are things you need to distinguish. A strong, uncomfortable pull is very different than a painful pull. So differentiate between the two. Uncomfortable is typically going to be like, I don't want you to hold this position, or I don't want to hold this position, but I can. And I know I can do it for a minute. Painful pull is when you get into that position, it might feel sharp, it might feel stabby, and you think to yourself, oh, I'm going to need something to bite down in order to hold this for a minute. You do not need to suffer through painful pulling. Uncomfortable is going to get you the result. Painful pulling is being a little bit too aggressive and can do damage. You can tear a muscle if you're constantly stretching it in a painful pull range. So always work in the area of discomfort and avoid painful. Again, this is with any muscle group, anywhere in your body. I wish I had the time to go through all the different types of stretches that you can do that would be beneficial for you. We just don't have that kind of time in that platform. So if you have those specific questions, again, I highly recommend reach out to your local physical therapist, have that discussion. It's going to be extremely beneficial to have a good stretching program in kind of your toolkit. That being said, after you exercise, you may feel sore. A little bit of soreness after exercising is normal. That soreness should go away within a day. If you're still sore within to the 2-day mark, again, maybe you overdid it. There are ways to assist yourself in reducing muscle soreness. And soreness can be just kind of an ache in the muscle. It can be an ache in the joint if you also have kind of the comorbidity of osteoarthritis. You may feel a muscle spasm, a muscle, which is kind of when the muscle turns on with movement. You may feel a cramp, which is just sitting at rest and you feel like that muscle is just kind of like a knot. There are many, many different over-the-counter ways to work on reducing your cramps and reducing spasms and muscle soreness. The top left for me, and I believe it's the same for you, is a massage gun. You're going to see these all over the market these days. And they come from a range of affordability from as cheap as $30 to extremely expensive. Getting yourself a massage gun can be helpful. If you have difficulty managing the device, hopefully you have a family member or a caregiver that can assist you with it. You do not need to put a lot of firm pressure through the massage gun when you're working on your muscles. That is going to be more for those like Olympic athletes that really need a knot worked out and dug into. What we do find is beneficial is that those devices actually vibrate. Vibration is what's really going to assist those neuromuscular junctions and those cramps and spasms. So holding the device lightly against your muscles will really help them to just kind of relax. And the kind of going along with that, other devices that do vibration, I have a few on here. You're going to see in the bottom center a bunch of platforms. Those platforms vibrate through the feet. So that's something that's out on the market now, that if you're able to stand up and stand on the platform, you'll get vibration through your whole body. Even if you're unable to stand and you just sitting in a chair, rest your feet on that, again, will assist in reducing cramps, primarily of the legs for that one. The last one, which is the bottom right that does vibration, is the Hitachi Magic Wand, and you'll see other devices very similar to it. A personal vibrator that, again, can be applied to different muscle groups to assist with reducing spasms. The general recommendation is to do vibration at a level that is tolerable. Again, should not be painful. Might tickle depending on your level of sensory awareness, or it might feel a little uncomfortable. Again, we live in the world of uncomfortable, but it should not be painful. Every muscle group that you feel like needs it, so maybe it's both of your legs, you really should be doing this for about 10 to 15 minutes on each muscle group. So this can be a little bit lengthy. This is where you're going to want a friend maybe to help you out because it can be a bit of a process. So that means if it's in both legs, 15 minutes per leg. Along with that recommendation, combining heat with vibration has been shown to actually be the most beneficial in terms of over-the-counter methods in reducing cramps and spasms. So my second picture from the left here is a heating pad. You can actually buy heating pads on the market now that also do vibration. If you go to our good friends at Amazon and type in heating pad and vibration, you'll see a whole slew of options of heating pads that now have small devices in them that perform vibration. That makes it a little bit easier because you can do 2 in 1 instead of separating the treatments. Again, heating each muscle group for about 15 minutes to really get the benefit of improving the circulation and reducing any muscle spasticity or muscle cramping. Supplements that can be added into the diet, I always recommend talking to your physician prior to starting any sort of supplement. This is not to say every single person here today will benefit from these, so it's very important before you start this that you consult with your physician first. Magnesium has been shown to be a natural muscle relaxant. Magnesium also can be a stimulant and help with constipation. It can also help with anxiety. So one of the powder forms of magnesium on the market is called Natural Vitality Calm. You mix a teaspoon or 2 in a glass of about 8 ounces of water, and again, can help to reduce muscle spasms, can kind of get the whole body to just get this feeling of relaxation. It also comes far right here in a pill form. Again, please, before starting any sort of supplement program, consult your physician first to make sure that that supplement won't have any negative interactions with any medications you're already on. Last one that may help with reducing spasms over the counter is tonic water. Tonic water has quinine in it, and it'll say it right on the label, tonic water with quinine. Quinine is the substance that actually assists with reducing spasms. I'm going to be completely honest, tonic water is not my favorite thing to drink. It's not that great, but if you're of age and can throw in a little swig of gin and a swish of lime, it goes down a little bit easier. All of these things should be done sparingly. You do not need to do these every single day, okay? This is as you are feeling symptomatic. If it's something you like, if it's something that you enjoy, that you feel like you get benefit from, you can absolutely do it every day, but you do not need to do it every day. With all of these, it is very important, again, to monitor your symptoms. I typically recommend if you're going to do any of these for the first time, better to do it closer to bedtime. And the reason why I say that is because if, God forbid, you're feeling a little extra tired, if, God forbid, you're feeling a little extra weak after any combination of these things, that is a normal response. But I don't want you to do all of this and then have to go to a family cookout, or I don't want you to have to do all of this and then go to your exercise session, because you might just not get your full energy levels. You might just not get your full effect. So it's going to be important to rest for a little bit afterwards just to see how you respond to it. Once you understand how your body reacts to these different devices, then you're fine to go about your usual business and incorporate them as you see fit. So, in summary, don't be a couch potato, but also don't go out and try and be an Olympic athlete. Find your specific sweet spot. In general, 3 to 4 days of exercise a week is enough. You do not need to do more than that. So for those of you who have been hearing information, I need to do something every single day, absolutely. You need to get out of bed every single day. You need to try and be moving around a little bit within your home every single day. But a formal exercise program really only needs to be done 3 to 4 days a week. Learn to love the middle ground. It's okay to try and stay at that status quo. That is what's going to keep you moving to the best of your ability for as long as possible. When in doubt, always consult your rehabilitation specialist. PT, OT, even speech language pathology if it is related to kind of that bulbar region. Always consult us. We are here for you. As we've been doing this discussion, I'm not even kidding, I've had 2 emails from patients asking questions. I love it when people ask me questions because we're here for you. We want to help you. We want to make your experience as positive as possible. We want to make you feel supported. Again, keep moving to the best of your ability. Make this a group or a family activity. Find a support system, because that's what's really going to help you do your best. And the last piece of advice I'll give you is be kind to yourself. Nobody knows what you're going through. Only you do. This is an extremely individual process. Please be kind to yourself and know that we're always here for you. Thank you for your time.
Thank you, Matt. All right. So we did get a couple questions, and Ginna, it was mentioned when you talked earlier about doing meditation and how that plays a role in ALS. Can you discuss a little bit more of how meditation can help with ALS?
So, relaxation techniques, it can be practiced when you're doing meditation. And right now, with the pandemic situation, there's a lot of meditations that they are doing through Zoom that you don't need to go to different places. And actually, they are doing in some of the parks. But meditation will help with the stress relaxation that it helps with the muscle spasms that is helping that Dr. Caraher was saying about that. I think it's a good thing to practice. Not only if you have ALS, any person that can practice meditation will help for the well-being.
Okay. And this one's for you, Matt. Some ALS experts do not recommend resistance exercise for ALS patients. What has your experience been with exercise in your ALS patients? Can you quantify an improvement with them?
So I will say that when exercising with ALS, it is extremely important to exercise smart, kind of the theme of the discussion. You can exercise with resistance. That information is a little bit outdated. And the reason being is because before we just didn't understand enough about the diagnosis. What we know now is that certain muscle groups can handle resistance while others cannot. And the way that we differentiate that in the clinic is by looking at your actual strength assessment. So when we are assessing strength, we always look at it on a scale of 0 to 5. 0 is there is no muscle contraction whatsoever. 5 is what is considered to be normal strength. What the evidence is showing now is if a muscle is around a 3 or greater, you can do light resistance. That doesn't mean you're going to go out and, be bench pressing 100 pounds. That doesn't mean that we're going to be doing any, 400-pound back squats, anything crazy like that. But it does mean you can safely use exercise bands. You can safely use lighter resistance weights. What we're finding is that with patients who are exercising at that level with light resistance in those muscle groups that are considered to be higher functioning, that we're seeing in general that they're keeping the strength. I cannot promise anyone that it's going to make them stronger. In some cases, we've seen that. I would say, and I'm sure Adriana can speak to this too, maybe in 5 to 10% of the cases, we've seen some strength increases, and that's phenomenal when that happens. But I'm not going to say that that's the norm. More likely we're seeing is those numbers are being maintained. The last piece to add to that, though, is when numbers are less than 3, when your therapist starts saying, this muscle is a 3, this is a 2, this is a 1, absolutely no resistance should be used. Instead, the focus should be on stretching to maintain range of motion and even just trying to move the muscles on their own, but without any resistance.
Okay. And just to comment on that too, do we need to see a physical therapist that specializes in neuromuscular disease, or are all physical therapists, because I know not all physical therapists are associated with neuromuscular disease. So is there a place where we could guide our audience to find a physical therapist that is, familiar with neuromuscular?
Absolutely. So I do think it's important to work with therapists that have some sort of neurologic experience. Now, if you're an individual living in a more rural setting, you might not see someone with my exact title as a neurologic specialist. You don't need to see somebody who's necessarily a neurologic specialist, but you should see someone who has neurologic experience. And one of the best ways that I can recommend that is if you go to the American Physical Therapy Association webpage, they have an option that says find a PT. And you can find a PT based on your condition. And basically, all the therapists who are associated with the association, which I believe there's around 350,000 of us in this association, you can type in, ALS, and it'll say, these are all the therapists in your area that say that they feel comfortable working with your condition. Now, if you're not a tech-savvy person, that's not a problem at all. Absolutely, just call the clinic that you're thinking about going to and say, I have ALS, do you think that you'll be able to handle this? I will not lie to you. Your therapist isn't going to say, you know, absolutely, and then make it up as they go. Most therapists, more often than not, if you have a condition they're not familiar with, they're going to be scared and say, no, I'm sorry, you need to go somewhere else. So more often than not, they will let you know if they don't feel comfortable taking your case.
All right, thanks, Matt. That's great advice. And our last question here, I'm going to give it to you, Adriana. Where can we get equipment to help, especially with hygiene? Are there certain companies or websites that you can recommend to find those kind of products? And also, what about YouTube videos for persons with ALS to help do some hygiene? Is there anything that you could recommend for that?
I don't have really information about the videos, but there are two like good websites about that can recommend assistive devices. One is performancehealth.com and the other one is ncmedical.com. And then you hit there and then they say ADLs activities and they have tons of ideas. The prices are not so crazy, but most of the, if you get the information, there are other places that might be a little bit cheaper, since most of these devices are not covered by the insurance. Like the bedside commode are covered, some of them are covered, but like most of the small items are not. And if you find like a good therapist, like normally they can even homemade the things that can make you like do things easierly. Like sometimes I just get like a little elastic band and I just put it in the hand and I said like, see, you don't have to hold your utensil, you can just use a band. So there are a lot of creative ways to make things to be a little bit easier. But those two websites are good. I can just write it in the chat.
Yeah, if you don't mind, can you type those resources into the chat? That would be perfect.
Right, I will do that.
What about Amazon? Do they sell? Do you use Amazon for anything like that?
Actually, I do. I just didn't want to say the name. I didn't know if I was allowed to.
That's okay.
But
yes,
yes. Anything, I don't get any business if you get anything from Amazon, but I have to be honest, it's amazing everything you find in these catalogs and are like at least 50% cheaper in Amazon, and you get it the next day almost. So
exactly, we gotta love that. All right, well, I don't see anything else. I want to thank all of you for speaking with us today and taking some time out. I know you guys have hectic schedules, so thank you very much for being with us today.